Okay, welcome to Fahrenheit Performance podcast episode number 5. Today we're talking about getting older as an athlete, and I have Dr. Ananda from Orthorcare here with me, and my lovely wife, Dr. Belinda from Performance Sports Rehab Specialists. Why don't you start by introducing yourself a little bit, Dr. Ananda?
Hey, hi Martin, hi Belinda. So I'm Dr. Ananda. I'm actually an orthopedic surgeon with Orthocare, Orthopaedics and Sports Medicine, located at Mount E Novena. And I'm very passionate about treating patients who are older athletes and treating their musculoskeletal problems and giving some advice on how they can actually continue to be active in their elderly years. So yeah, very thrilled to be here today.
Belinda?
Okay, so I work at Performance Sports Rehab. I started this practice 7 or 8 years ago, but I've been practicing in sports for the last 20 years. Started my practice in America, working at Palo Alto Medical Foundation with surgeons who work with professional athletes. And so we do see lots of different sports, probably slightly different from the ones I see in Singapore. But still, I definitely felt like I was trained in a way that we were thrown a lot of good post-surgical patients, as well as a lot of American football patients. Over here, in our clinic, we see a lot of athletes from different sports as well, like rugby. I do have a soft spot for dancers and gymnasts. So and I do, since we're now post-COVID, we see a lot also of chronic pain patients.
Mm-hmm. So today we're sort of talking about the aging athlete. These guys have a lot more experience than I do about this, so I'm just going to sort of moderate. But I guess start with you, Dr. Ananda. An aging athlete, right? We're talking about someone who is physically active, has been all their life, but now they're finding that they're getting older, right? Like for me, right? I used to run a lot, and then suddenly I do a half marathon and I pass out, right? So what is different between me then and me now that is like what's going on in the body?
Yeah, so I mean, when we talk about athletes who are older, I mean, there are 3 main things that happen. One is there is a age-wise decline in VO2 max that athletes do undergo. There's also a decrease in muscle mass as well, and increase in fat. So these are three more most common physiological changes that athletes who get older can experience. And I think if you're an athlete, there are also other considerations to take note of as you grow older. I mean, how consistent are we in our training? And what kind of training or the components of training that we're doing. I mean, it is certainly something that's very sports specific. I mean, we know that there are endurance sports, and then maybe there are sports that are mainly not really more endurance based, but maybe more it's based on movement, for example. Like, I mean, dancing is considered a sport as well, you know, so but it's not exactly considered an endurance sport. It's got other aspects of it that are also important as the athlete grows older. I mean, like, you know, what's happening in the joints, the muscles, you know, the stiffness, the mobility. So there are different aspects, I think, that we need to consider when we actually assess athletes. And yeah, so I think there are certainly many considerations to take note of. But I mean, physiologically, I would say that the 3 most common things that would happen would be VO2 max decline, fat increase, and muscle loss.
So how about you, Belinda? With let's just say we have 2 footballers come in, one is 20 and one is 40. They both train pretty much the same. What would be the biggest difference between the 2?
I think it's quite common kind of population we see here. We do see the very young and the very old. It's very old, but actually maybe the 40 and above, they're still doing their weekend warrior sort of activity. What I notice most is these athletes actually have accumulated more over the years. So I think physiology-wise, to me, is not as big of a component as lifestyle. So for example, they come in and they tell me I play once a week football, but I am sitting in front of a computer 12 hours a day. and I want to address the problems that had accumulated with that 12 hours a day activity as well, because that's probably what's maybe making their disc flare up in their low back because they sit too much. So I feel like I know people always come in and tell me, oh, I think it's aging, but actually what they really mean is the things that have accumulated over the years have now taken a toll.
Yeah, we get that with Bike Fit all the time, right? We got let's just say they're an accountant and they work for 12 hours a day, and then they jump on the bike and they expect to be fantastic in that position, and they wonder why it's so difficult to maintain the position, and it's so hard on their back. It's probably maybe not the bike, it's actually what they do during the day that's contributing.
Absolutely. And I think akin to what you've said, Martin, I think that aspect where they have been sitting for maybe long hours and having the pain after that also suggests that, as I mentioned, the muscular component, which is something that is not addressed adequately for them. I mean, it's something that they may have actually neglected when they were younger, because when you're younger, you could probably get away with maybe not doing any,
right?
Yeah, that's right, absolutely. But
you could party all night long and then wake up and go to work the next day and not an issue, but
absolutely, yeah. And it is known by studies that muscle mass and collagen type 1 fibers, there's a stepwise decline of these fibers as we grow older. So sarcopenia, which is muscle loss, is something that is common, and it happens insidiously as we grow older. And this is also one of the bases why musculoskeletal problems occur. So
I was watching a documentary years ago about as you get older, there's like some cell in the body that has a long tail, and every few years a little bit of it drops off, and then so the older you get, the shorter that is. I didn't quite understand it, but I think you probably
understand. So it's true. So longevity is based on what we call the telomere length on the chromosomes, and the telomere lengths on the chromosomes actually get shorter as we grow older. And what studies have shown is that it is also seems to be related to VO2 max.
So that's how the body knows it's old, right?
Absolutely.
Is that how it is?
Okay. That's right. So one of the predictors of longevity, interestingly, actually is your VO2 max. Okay. And if you can maintain a higher VO2 max as you are growing older, which essentially means less sedentary, more activity, this would actually help to stave off aging.
So VO2 max goes down. It's not a constant throughout your life?
Yeah, so VO2 max is expected to decline as we grow older, but the rate of decline is what training and activity, exercise hopes to prevent. And that's also the something that I notice when we talk about the aging athlete. It is very common that as we grow older, we tend to gravitate towards things that we feel more comfortable with, even as an athlete. I mean, you can be very consistent, but maybe you may be doing something that's very comfortable, consistent, something that you can do regularly. And unfortunately, a lot of that activity may be based on endurance, maybe longer activity, but the intensity of it may be lacking. And there may be a natural gravitation towards less intensity, but it is always wise to add some intensity in that activity as an athlete, just so that you keep your VO2 max levels topped up.
So that's why the youngsters do the Olympic and the sprint distance triathlons, and the older folks, the 35 to 55s, do the 70.3s and Ironman, right? It's I guess you gravitate to what you're good at, right?
Yes.
So and then heart rate max, right? There's an old formula for heart rate max. It's 208 minus your A or something like that. Is that relevant? How does that work?
I mean, I think there are studies that show that heart rate is very variable, and I think the formula itself may not be absolutely accurate in predicting what your heart rate max is supposed to be. But I think the better measure of this is your training, your history, how you actually perceive your heart rate max when you're doing your activity, which is
probably the full picture.
Yes, exactly. Yeah. So yeah, I mean, a simple way to think about it is like I think heart rate for patients, a lot of patients that I see in the clinic who I'm giving some sports medicine advice to, many of them may not have a heart rate monitor. So I usually use more like what kind of sensations you feel, or a kind of a measure. Like, for example, if you can have a conversation and sing at the same time, that would mean zone 1 essentially. It's like a very recovery, very light pace activity. Well, if you can have a conversation and maybe can't sing, that would probably be like zone 2. Okay. So this is like very it's very basic that you can tell them, advise them. yeah, on how you can actually moderate your activities as the week, as the week goes by. Yeah.
So, Belinda, how about something like a back, right? One of your favorite subjects. Back, yeah, lower back, or even upper back and neck. How does that vary when you're getting older?
So if I have to take like the bike fits that I do as an example, so a lot of the bike fits that I do, I find like it doesn't matter young or old, it's how they were using it to begin with. And so when you put them on the bike, definitely you can see also what they have been doing. So if I look at them, their thoracic spine, which is their upper back, might be really stiff and they keep fulcruming from the neck, then I know they might be in a sedentary job. And so, which is also how then I would prescribe certain exercises for that to help to mobilize that area so that it puts less strain in the neck. So is that...
So as the years go on, does it stiffen up more and more and more and more and more? What can you do to let's just say when you're 25, you understand that this is going to happen. What should you do from that point onwards to not become like a stiff 45-year-old?
So I feel like some people are more predisposed to joint stiffness, for example, and some are less so. So if I find that somebody young have like a stiff joint, I sometimes wonder if there had been something had happened, like if they have had some whiplash injuries, sports injury that had caused some concussions or that came with a whiplash too, then I would expect some degenerative change earlier than later. So these are the ones could be in their 30s, but their spine and the MRI looks like they're 65.
And then you give them exercises, or you give them sort of techniques to keep as nimble as possible for as long as possible? So
the mobilization techniques that I do for them helps to so-called lubricate the area, or it's almost like a passive mobilization such that it helps to, it helps to lubricate the area. But I want to say if they're in grade 4 kneecap, where like there's wear and tear there, I find that it's still very hard to depend on conservative rehab skills. I still need someone like Dr. Ananda to help me either with like PRP or things that are to help optimize their joints, to help me out with my rehab as well. So sometimes then I'll tag team with someone like Dr. Ananda to help patients who are in such a level of wear and tear.
So if you're a runner, for example, right, and you only run, do you recommend like seeing Dr. Ananda? For me, I consider you to be the last resort. I don't want to see you, right? I'd rather just to see you and be taught something than to see you and be operated on, right?
That's what they think about you.
Operation is always the last resort.
Yeah, exactly. So is it a matter of cross training? Like cyclists are notorious for, let's just say they do 10 hours a week of training, and then one fine day their family's away and they've got 5 more hours a week. They will just cycle 5 more hours, right? They won't think about going for the gym or going for a run. Is cross training? Do you recommend?
I think cross training is very important. So I take myself for an example. I play tennis once a week with a coach, and I can feel it in my hip after I'm done. I also know that part of it is because after my pregnancy, I've had some hip issues and that I didn't fully resolve. So I know this is something I've also accumulated in my life. So on Saturday I play with him. On Sunday I have Pilates, and usually my Pilates instructor will find that I have issues with my pelvis or my hip. But if I don't play tennis, he'll find, oh, you're looking really great today.
Nice.
So I know I'm killing myself while he fixes it, and I have to keep doing that because I want to play tennis and I want to play hard. So I'm 47. I don't want to play doubles yet. I want to stay with singles. I know most people at this age have switched to doubles, but I still think with good conditioning, like going to the gym a couple times a week, working on certain muscle groups that are related to your sport and sport-specific exercises is really key to rehabbing or preparing you for the sport that you're playing. So I take this as being responsible to your body whilst you pick your sport.
What about doing something that is not particular to your sport? So for cyclists, they're very two-dimensional. They cycle and their legs go in one way, but the stabilizing muscles side to side to side don't particularly get worked out. Would it be beneficial for them to go running every once in a while to sort of get those foot stabilizing muscles and the hip stabilizers a bit stronger, so it would have actually helped them with the cycling?
I wouldn't use running as an exercise to rehab for cycling, for example. I would probably consider for cycling. What's very special to cycling is 5 points of your body are in contact with a surface: your butt, your two hands, your two legs. So it's a very unusual situation where running cannot replicate. So I find that Pilates is super helpful because you can find different positions where you can still somewhat replicate cycling position to activate your glutes, or which I find most, for example, if cycling is what we're talking about, glutes are usually the ones that fatigue pretty. It's a big muscle. We want to use it together with the core to power the bike. But a lot of times when we start to fatigue during the endurance sport, the quads will be the ones that take over most of the activity, and hip flexors, which explains why the experienced cyclists often actually look really tight at the hip flexors. And so these are the athletes that really need a lot of recovery work with, and that I mean also sports massage and then rehab.
Yeah.
So Dr. Ananda, you're actually a pretty seasoned cyclist, right?
Yes, I try to be as regular as I can.
Do you notice as you're getting older, do you get like more injured, or is it take longer to recover, or what's going on there? What do you think's going on there?
Yeah, so I mean, personal experiences in cycling. So I've been cycling since my 20s, and in my 20s I was pretty regular with it. But then in my mid 20s, I took a long break because I was considering my work as a doctor, and so I took a break from the sport, and I came back after that. But yeah, you can certainly feel it's very different when you're back. Certainly, number one, your muscles are gone, not conditioned at all. But coming back from that, and I got more conditioned, I realize now in my 40s, there are differences I've noticed. Number one, I need to do a lot more stretching before my rides, because as Belinda mentioned, when you cycle very often, you tend to develop a lot of tightness in your flexors. And you tend to neglect this very much until you actually see that friends are saying that, oh, you seem to be walking with a bit of a hunched posture, and then you realize that, oh, actually it's affecting me. But although I know I've no symptoms, but when you really take a deep dive, do some stretching, you realize that, hey, your posture is better, and that helps every aspect of your musculoskeletal system. When your posture is better, you actually protect your spine, your muscles are more balanced, you prevent a lot of injuries in the spine as well. And I think the other aspect I've realized is that as I'm growing older, I've noticed that I've also had to pay attention to strengthening as well. I mean, stretching is one aspect, but I think strengthening is also important as a cyclist, not just to, of course it may have a performance benefit, but it also has a benefit in helping to prevent injuries. And especially, I've realized that, when I actually try to do a conscious strengthening workout on a regular basis, I realize I don't have anterior knee pain. Sometimes when you push a very high gear, very high torque gear, you can tend to have some anterior or knee pain on the front of the knee. That's probably because your muscles are not so adapted to that. But, after strengthening, you realize, hey, pain is gone. So I really can see a difference that strengthening can bring to athletes, especially those that are growing older.
So, VO2 max and sort of as you get older, your VO2 max goes down a little bit. Is that because just we gravitate to the more endurance-y sports? Do we not have enough intensity? Should we be doing VO2 max workouts to boost that VO2 max, or what should we do? So let's just say in 20 years' time, when I'm 65, 67, almost 70, whatever, should I try to throw in VO2 max? Because then is my heart going to be able to take it?
So, of course, everything has to be done with some sort of progression at the end of the day. But yes, I think it is always good to actually include some high-intensity workouts. in your weekly workouts, I think, you know, if you've not done it before, it's always good to just start in terms of, I think, just maybe one session a week perhaps, and then maybe you could just increase as you go along. But I wouldn't go as much as more than 3 sessions a week. Actually, I think 2 would probably be adequate for a very consistent athlete. I mean, I'm talking about cycling, but I think it goes towards, you know, even running or other endurance sports as well. So just maybe 2 sessions would be good, but always build up to it. I think if you've not done VO2 max workouts before, high intensity workouts, it's always good to have a good base, which I assume if someone has been doing consistently endurance based activity, they would have at that base. Then you could probably just throw in a couple of efforts, maybe a 1 session a week.
Or what happens if you only do 1 session a week?
Sorry,
if you only do 1 session a week, then should you just, during that ride, you just go to do some hill repeats or something?
Yeah, absolutely right. I think that would be good enough, actually. Yeah.
Okay. How about you, Belinda? I was just thinking, like, if someone comes in with they say they've got a muscle strain, or my foot hurts, how do you tell if it's a muscle strain, if it's a tear, or if it's a stress fracture, right? It's just painful. They don't know what the heck's going on.
I get that question every day in my house, because there's 3 kids who come home every night and they try to get a treatment.
Free consult.
And they're the worst patients. But so every day I have these 3 who comes in to ask if they fractured something, or they sprain an ankle. And sometimes I don't believe them. But I have found some interesting things as I assess them. So there are a couple of things I would look out for. I think the subjective history is very important. So I do ask I do have a lot of questions to ask usually. For example, if they have pain with loading, so it could still be either a bone, it could still be a muscle, because when you load a muscle, it will hurt. If they lie down and the pain goes away, it's likely that it's not a muscle. So usually muscular pain is, we would test for strength. If it's painful and it's a little bit weak, it's likely to be either a strain or some tear, but I don't know until I send them to Dr. Ananda, who either they do an diagnostic ultrasound, or send
X-ray.
them for MRI, and that is the most definitive answer. But a lot of times when we manage a condition like this, sometimes if it's not a very severe one and we can treat it conservatively, we'll do that for then. And if a couple of weeks it doesn't look like it's better, I'd be sending over to an orthopedic surgeon to get them checked for if it was something more serious.
Okay, so that was actually my next question. So when do you recommend rehab versus surgery? Or let's just say someone walks in and says, I need to get surgery on my knee for an ACL. We do prehab, right, a little bit? Or when's a tipping point between, okay, this actually needs surgery?
We do some mental tests in our room, and from our mental testing and the subjective history and understanding the mechanism of injury. So what I mean is, I always ask, how did they fall? For example, for a knee, right? If it sounded like something that could have twisted out that ACL, I do some of the ACL checks. And then I also have to realize that I'm limited by certain things, like if there are more swelling and there are more pain, it could skew my testing as well. And if I'm not sure, sometimes I have one of my colleagues double check. If I still feel something's up, I'd send over to the doctors, and they will do their mental testing, and then they'll consider either, if they feel it's something that they will investigate. Usually you guys will do an MRI or X-ray, whatever test that's important for diagnosing the condition, and that's how it happens in my room. But you can maybe so if someone has got a knee injury, for example, and they come to see me, I mean, of course, the first thing that usually I would ask them is how was the injury. I mean, the mechanism of injury usually lends itself a lot to the diagnosis. ACL injuries are usually twisting injuries of the knee, and I mean, you could get ACL injuries from common sports like football, basketball. And well, usually when you have an ACL injury, what's most common is that patients would immediately say that they've noticed a huge swelling
in their leg or in the knee once the injury happens, as opposed to, like, let's say talk about a meniscus injury, which is another structure within the knee. The swelling usually comes on after a few hours. So some parts of the history would lend itself to the diagnosis as well. I mean, true enough, it is very accurate that what Belinda said. If there's swelling, you can't exactly assess them properly, and they are actually in pain. So I usually will take a more expectant management of them. Maybe let's do some rest, ice, compression, elevation over the next 1 week. Let's see how things go. Maybe I'll assess you a week later, and let's see how that goes. I mean, so sometimes they come back a week later and you're able to do a bit more of the ACL specific tests, like maybe the anterior drawer, or what we call the Lachman's test, to check, if the knee is stable. And then there's another level after that. Let's say, for example, you detect the knee is unstable. Then you tell them, I suspect you may have a ACL injury, but it's always better to check with an MRI scan. Because an MRI scan would also give us some indication as to, is there any concomitant injuries other than just the ACL. Some things that we commonly find is that the meniscus is injured, or maybe some of the collateral ligaments of the knee may be injured as well. So these are part of the diagnostic procedure.
So when would you send to physio as opposed to surgery?
Correct. So that's where I think the conversation with the patient is important. So I think that's where the context of the nature of the patient who comes to see you. So now, ACL injuries can be debilitating, especially if you're a sportsman and you're intending to go back to your sport at the same level as you want to, because you will realize that your ACL is unstable, and that may predispose you to get more further injuries, recurrent swellings, and maybe even in the long term, maybe the risk of arthritis as well, or even meniscus injuries. So in those contexts of patients, I would say that you should explore the option of maybe a surgical treatment, because you want them to get back to the activity the same way they have been, and then the physio will start after that. But of course, there are also patients with ACL injuries who are relatively, their lifestyle doesn't really require them to actually do a lot of twisting movements, or they're not really involved in very high intense sport. And if in those kind of contexts, I think they would benefit from maybe a course of rehab and physio. And they would probably be very functionally well after that.
So as long as they're not going back to intense sport, where they...
Yeah.
Okay. So then, you just mentioned arthritis a little bit. So I always think of injuries as, let's say you're 100% before the injury, you get injured, you get it down to 80%, you can build yourself back to 100%. But arthritis is almost like a one-way street, right? You slowly get worse and worse. How does that play into this as you get older?
Yeah, so arthritis is a degenerative condition of a joint. Essentially, it can occur in knees, it can occur in the ankles, it can even occur in other areas of the body, even the neck, the spine as well. Yeah. Now, as much as I wouldn't really say arthritis is a one-way street in the sense that it just declines over time, because there are ways to actually prevent arthritis from getting worse. Okay. And a lot of it has got to do with loading, because the joints at the end of the day are meant to actually withstand load. And what happens when there's arthritis is that the joint has undergone some wear and tear, and that wear and tear could be from injury, or it could just be from chronic degeneration that happens as we age generally. Now, I've seen patients who have got injuries and maybe arthritis, but they have actually coped very well with their activities with a good physiotherapist like yourself, and also, of course, with strengthening activities, and also attention to just basically some modifications in their lifestyle, and they can actually live very fulfilling lives without problems henceforth. But of course, I've also seen patients on the other extreme who continue to get worse. And the reason why this happens are multifactorial. So there could be alignment issues of the spine, or alignment issues of the knees, and these things, they just don't go away. They're just there, and they actually make the problem worse. You can try footwear modification, you can try knee guards, you can try injections. Things like this are present to actually help to delay the onset of painful arthritis. But after a point in time, I think the conversation happens to how much is this affecting your life? Are you happy? Are you able to function in a fulfilling way?
So if you have arthritis, I guess if you take proactive steps to fight it, for use of no other word, right? You can actually sort of delay
yes,
it.
Certainly.
Okay, it's not just because I guess some people just, when they get it, they'll just give up sports.
Yes.
And then that makes it worse because they've given up the sports, right?
Absolutely, yeah. So, I mean, I think that's a very fair point because now, I believe very strongly in the adage, exercise is medicine. And I think it's very true in arthritis as well. I mean, a lot of patients feel that they can't exercise because they have joint pains. But, I mean, I would say to them that, there are other activities that may not be so much of a load-bearing activities that may actually help you get a good workout. It gets your muscles active as well, and that's what we want to do. We want to get some strengthening. We want to get that neuromuscular function of the muscles going to actually help to prevent the arthritis from getting worse. Yeah.
So, Belinda, what do you do when someone comes in and they've got arthritis? Do you modify their exercises, or how do you treat that?
So, of course, it depends on which body part, and if I were to say maybe if it's the knee, for example, again, a load-bearing joint, I think, so if it's not too serious and they're not so symptomatic, usually I would still do land exercises. I start off on the reformer. But before I start exercises, I would assess the joint mobility. So if they have already stiffened up by quite a lot, it's already going into the vicious cycle of not being able to take load very well. So I try to restore as much as I can the joint mobility, either in the kneecaps or the knee joint itself, and then before I start them on a gradual increase in load bearing. So starting off with, the reformer, the great thing about the reformer is that even if you're 80 kilos, you're laying down doing your leg press, for example, I can make it 25 kilos. So that's a lot easier for me to manage. So they want to lose weight so that there's less load bearing and compression of the knee, but they can't do that. So a lot of times they just give up. I cannot run, so I can't lose weight. Now how am I going to help this joint, right? So I feel like the anti-gravity treadmill is another option. Although I do think again Pilates is another way you can gain some endurance. Cycling would be great with the load bearing. So I think education is really important also on how to, if they like going to the gym, how to do your squats better, so you spread the forces to other parts versus your knee. So some of this will help them manage the situation. Once they feel empowered because they know what's going on, they're able to comply with some of these exercises.
It's a bit of a vicious cycle, isn't it? If you get injured and you're let's just say you ride 3 times a week, and then you get injured and you can't ride for 3 months, right? Then suddenly you try to get back, and you're probably 5 kilograms heavier, and you're so much more unfit, and everything is so much harder, right? And then some people just never get back to their 3 times a week. They'll say, "Oh, I'll just do something else," and then it gets worse, and then suddenly you're 10 kilograms heavier. Not speaking from experience or anything, but suddenly it's so much harder, and sort of, unless you got to get back in the groove. Otherwise, 5 years will pass, and you'll never get back to where you were before that injury. And it's all it was a one trigger, and it was knee injury or whatever injury, and it's sort of you regress so far back.
Yeah. I think that's one thing that it can happen. I think friends or common friends or a social aspect of the activity. Like a group will be encouraging, because I think that the social element itself will get you out, and I mean the consistency would come after that, and I believe the consistency is the key, because I mean I think even if you can do but maybe half an hour, but if you do it consistently, I think it goes a long way in getting you back
for sure.
motivated.
What's that saying? It's like, I might run slowly, but I'm running faster than sitting on the couch. It's like so consistency over the years as you get older is going to help in the long run, right?
Certainly, yes.
Okay. I think that's a lot to digest for one day, and it's getting late. So I'll thank you, Dr. Ananda, for coming in, Martin, and thank you, Belinda, for talking to us about getting older. So how do we get a hold of you, Dr. Ananda? Is it just at Dr. Ananda on Instagram?
So you can find me at my website, orthorcare.com.sg. That's it's my company, it's my practice, and you can find me there. I'm also practicing at Mount Elizabeth Novena, Farrer Park Hospital and Parkway East Hospital. And if you need to contact me, I'm on Instagram as Dr Ananda Vela.
Mm-hmm. Dr.
Dr Ananda Vela.
Ananda Vela. Okay.
Yeah. And yeah.
And then you, Belinda, it's Performance Singapore at Performance Singapore on Instagram, right?
That would be best. I'm terrible at email. I've never checked my email, so don't contact me by email. Just call 673-43421.
And you get a landline, old school.
You get the landline, and you will get Stephanie on the phone, and she runs the show.
Okay. Nice.
Thanks a lot, guys, for your time.
Thank you.